I wanted to talk about the primary results of lurbinectedin plus atezolizumab as first-line maintenance therapy for patients with extensive stage small cell lung cancer. Does anybody feel very passionately about perhaps what this showed?
Pretty excited about this study, actually. I am one of the authors on this as well, so I'll mention that up front. But this is a study that looked at maintenance lurbinectedin. Lurbinectedin approved in the U.S. in the second-line setting after first-line treatment for small cell lung cancer in the advanced stage. This is an alkylating agent. It's transcription inhibitor, and this is an active drug. And the question is, if we give it earlier, does it help patients? When we think of maintenance in small cell, the reason why we keep going back to this well is that this cancer consistently responds to chemotherapy. We're very confident we're getting a response. We're also very confident it's not going to last. Median PFS of 4 months means people progress right after or during chemotherapy. So it's not a very good treatment, despite that being our treatment for many years. Immunotherapy improved survival for a subset, but most patients are still going to relapse. And we also know that at the time of relapse, a large number of patients do not receive any further therapy because it is an unforgiving process. It is a devastating event progression. And about 50% of people will get second-line therapy. And so that's a huge attrition. Can we give therapy earlier? And we've tried many maintenance treatment strategies before, all of which have failed. This is a study where we added lurbinectedin in the maintenance setting with atezolizumab. So chemotherapy, carboplatin etoposide, plus a PD-L1 inhibitor, atezolizumab, and then maintenance after cycle 4 is either atezo with placebo or atezo alone or atezo with lurbinectedin. Did require primary growth factor support to sort of combat the myelosuppression. Up front, we expect we'll see more responses. We expect we'll see a better progression-free survival just by instituting a new non-cross-tolerant therapy earlier, and you're going to have more toxicity. That's what we expect, and that is what we saw. The big question, does it translate to people living longer? And it did. And we'll see the exact numbers tomorrow, but we saw this extended survival, and I think that's not something you can dismiss. By moving therapy earlier, people live longer. You give patients a chance to get an active drug, and if you wait until progression, you can say, we promise we will give this to you at the first sign of growth. 50% of the time, you won't be able to keep that promise.
On the flip side, I'm equally excited. I am. Yes, any big change that we can have for our patients with small cell lung cancer is huge. We haven't been able to see a maintenance benefit like this, and this is like the first real recent benefit actually in this setting. So what I will say is that we have to be very mindful of the toxicity and tolerability of this, right? Because now we're taking away that opportunity for a chemotherapy-free interval, for that chemotherapy break that patients wait for after they get their chemoimmunotherapy for their induction, and then they switch to normally just immunotherapy maintenance, right? So we're taking that away. So we have to be very vigilant about the toxicity. We have to make sure that they can get onto another subsequent line of therapy if they need it. So I would not be afraid to take a break, to consider dose reductions, things like that to support them through that maintenance journey, and just being very, very mindful of their quality of life at the same time.
I think it's a good point. But if the median PFS is 4.5 months and 3 months is chemotherapy, the median break is 1.5 months, which is one scan. So it's a break.
It's a break.
It's not typically that long of a break anyways.
Well, and I think this brings into my question also the shared decision-making, right? This is not going to be for every patient, right? So, I think, to your point, Eric, when patients have finished frontline therapy, many of them just don't want to keep coming into the infusion center. I mean, in this trial, obviously patients went on to get either maintenance atezo or atezo plus lurbi. So they'd still be coming in. But I do have some patients where it's just not worth it for them to get that addition of chemotherapy. The immunotherapy maintenance is a little bit different, right? And now we have the, every month infusions. And so you're bringing people back to every, 3 weeks, right? And then the toxicity with the chemotherapy. I have patients, and small cell is near and dear to my heart. I treat a lot of these patients, particularly in my VA practice. And these are not patients who are going to be able to necessarily always be able to tolerate those toxicities. In the beginning, the platinum etoposide, great. You get patients out of trouble. But then in the maintenance setting, I think it's tricky, right? You're not necessarily going to be making them feel better. In fact, you might be making them feel worse. And it's that balance. I think it's trickier in these small cell patients than in the non-small cell. And so I think it's going to be a discussion. It's going to be something we're going to talk about, and it may not be for every patient.
All excellent points, and we'll just throw one in there in an optimistic manner, and that's even at least the thought that as our toxicity management and agents on what they can do in bone marrow support, and they get craftier and they get more kind of effective. Hopefully, it will at least mitigate the tolerance issues, and now you can look a little bit more closely at efficacy of anti-cancer treatments because you have things that are coming in the pipeline that make toxicities more bearable. That was a great debate. It's the first actual debate. I like that. And then lastly, we have time, right? What? 1 minute? Okay. One in 60 seconds, can we talk about the primary analysis of tarlatamab versus chemotherapy as a second-line treatment for small cell lung cancer, especially if we're using lurbinectedin in the maintenance therapy in the first line. So how do we feel about that?
I think tarlatamab is an important drug. I think the durations of response are undeniably exciting. And this is a positive study for survival. The control arm is pretty heterogeneous here. Not everyone gets lurbinectedin. There's a lot of topotecan here. And in settings where you have certain factors, topotecan wouldn't necessarily be our standard of care, but this is a positive trial and I think an important drug. You mentioned at the top, though, access, and I think that remains to be an issue globally, but also here in the US, that this is a drug you're admitted into the hospital with 23-hour reservation for day 1, day 15. You need to be near a hospital. You need to be willing to come. It's a deal breaker for some people, especially those that can't really take that much time off of work and so forth. So there are some obstacles, but I do think that this is the future, and I do think that this is something that should be considered for everyone outside of a trial. I think it's just impossible to deny.
I agree. I think we're seeing these T-cell engagers. I think there was data presented at this meeting about now these tri-specific T-cell engagers also. So a lot of excitement about the T-cell engagers and the I think the potential for these durable, potentially even cures. We never talk about cure in extensive stage small cell lung cancer, but we are seeing that in patients treated with tarlatamab. So I'm personally very excited about tarlatamab and some of the newer T-cell engagers that are also being kind of developed now in this space.
No debate. I agree.
And this is the only one you said you weren't excited about?
I'm excited about this, actually.
Excellent. Well, thank you all so much for that. You can see how profoundly brilliant and helpful this is and really optimistic in a very challenging disease process. So thank you all very much.